is really a pleasure to have the opportunity to speak today with Dr. Shiriki Kumanyika, who's very well known to many of us here in this community, but I'm going to go ahead and give a brief bio, if you don't mind. So Dr. Shiriki Kumanyika is a research professor of community health and prevention at Drexel University's Dornsife School of Public Health, and emeritus professor of epidemiology at the University of Pennsylvania. So Dr. Kumanyika's expertise is quite broad, but it's largely in public health, nutrition, and strategies for achieving equity in the prevention and management of obesity and other diet-related chronic diseases. Much of her research during the past decade has focused on the racialized targeted marketing of unhealthy foods and beverages to Black children and adults. Dr. Kumanyika was the founding chair of the Council on Black Health, which was formerly known as the African American Collaborative Obesity Research Network, or ACORN, which has a mission to create healthy Black communities. Dr. Kumanyika also chairs the Food and Nutrition Board at the National Academy of Medicine and the Nutrition Guidance Expert Advisory Group for the World Health Organization. She is a past president of the American Public Health Association as well. And this year, we are very excited and privileged to have her giving the David Kritchevsky Memorial Lecture on Implementation Science as a Pathway to Equity-Competent Obesity Solutions. Shiriki, if I may, it's really wonderful to have you here today.
Yes, nice to be here. Thank you.
Thank you very much. So maybe I'll just start with a big picture question, if that's okay. Why do you see it as critical for us to be conceptualizing obesity through an equity lens?
Well, obesity is a complex problem, and as one of my colleagues has recently put it, there are causes and there are contributors. And the contributors are really embedded in society because eating and physical activity and weight control are parts of the social fabric. It's not something that you can just park until you want to think about it. You're eating every day and being active, and how you do that is determined by your circumstances, the context you live in, your family, your attitudes. Because I think we now admit that structural racism affects the living context of people in some populations, and Black Americans in particular, throughout their lives, throughout the life course, and limits opportunities. And because of that, when you try to address obesity, you can't think of it as a medical problem, where, like blood pressure seems simple by comparison. Mm-hmm. It's one part of physiology, and you have now good strategies for lowering blood pressure, and they are medical pharmacologic strategies. With obesity, there's no way to really address it without interfering with your day-to-day life on a constant basis and picking up the whatever baggage society has given you in terms of your ability to eat healthy and be active.
That is very helpful, and I think we see you today. I and many others are just so inspired by all that you do and all that you've done. But taking a step back, can we just talk about how you got started in this field in the first place?
Well, I think I started off being raised in a segregated town just below the Mason-Dixon line, Baltimore, and was always aware of health issues in the Black community because my father was a general practitioner. He'd gone to Meharry Medical College, and I used to go to his office and help him, talk to some of the patients when they were waiting, to see him. And so I just got a picture that people in this particular neighborhood where his practice was just had a lot of issues. Some of them didn't have money to pay. He would say, well, you could wash my car, and we'll, trade it like that. And so I grew up with the idea that I needed to do something to help with the health problems of health and social problems of Black Americans, because in those days, that was, if you had privilege as a Black person, that's what you were supposed to do, is help bring others along with you. So it was just kind of natural that I went first into social work, and then I went into public health. Once I discovered it, you couldn't get me away from public health.
Well, I want to ask a little bit more about social work in a moment, but just to kind of piggyback. So obviously, it sounds like you had an amazing role model in your dad. Are there any other mentors or sponsors from early on that were instrumental in your journey?
I think it was the whole community, because one of the characteristics of segregation is that you're around a lot of people who don't have opportunities, so they make opportunities within the culture. Like, we didn't have, couldn't go in to eat in places when I was young and stuff like that. And so it was really like the village. Black physicians or Black teachers. My mother was a school teacher, and people all rooting for you. And if you got good grades, good report card, the neighbors would, give you some money to go buy some, So it was, I think that in that sense, those were mentors. And I have one uncle who worked for UNICEF. He was a teacher, and he started working in UNICEF. And he was a mentor in the sense of having moved out into the global world with visiting, not UNICEF, UNESCO.
Okay.
Yeah, my uncle worked. Yeah, he worked for because he was a teacher. He worked for UNESCO, and he visited programs in different countries, and that he was a global man. He taught me that there was a world outside of Baltimore, and used to come to visit me when I was in college, take me out to dinner and talk about what he was doing. And so I think that I consider him a mentor because he achieved more than some of the other people. There were doctors, but he had achieved more and in a different world. And he inspired me not to think of myself as in a very narrow environment.
That is really helpful and important. And as somebody who's in Baltimore right now, just thinking about how you develop that sense of possibility is a really wonderful thing to hear.
Yeah.
So obviously you had some formative experiences just from growing up in your community, but you've also mentioned, there were some unique aspects of your training background. So you, I think as an undergraduate, you had a psychology degree major, and then also trained as a social worker. So how did those training experiences or those aspects of your training background contribute to your perspective as you started engaging with these questions of nutrition and obesity?
Undergraduate was a culture shock for me because I went to what's now called a PWI, predominantly white institution. My sister went to Fisk University, which is a black, historically black institution. And so when I went to this large white school where there were only less than 100 black students, that reinforced my idea that I needed to be able to do something with that opportunity that would help black people because, there was just so much to be done. A lot of the men were athletes and came from low resource backgrounds. So it broadened my horizons to see how something like athletics, for example, could become a way out of poverty. And if you have that lens where you see injustices, then you can't take it off.
Yes. Yeah.
You know what I mean? You can't take it off. So I saw that, and I saw the students, treated me. I was treated well there, but I just felt like I was a little, a small snowflake. Syracuse. There's a lot of snow in the in this broad world where just about anything could happen to me, and but there was nobody there interested in helping me in particular, you know.
So that sounds like in some ways isolating, in some ways opportunity.
Yeah, that's a good way to put it, right?
Yeah. You've had a lot of really amazing steps along your journey, different institutions, Cornell and Hopkins and Penn and Drexel. And one of the things that you're well known for is that you've done lots of trials of diet and exercise and weight loss, particularly among African American women. So, you know, as you engaged with those populations for these kind of interventions, I'm wondering what are some of the things that you learned from those experiences or you took from those experiences that has shaped some of your current worldview?
Well, I learned, first of all, that, and this may be part of what you were asking about before, I learned that surviving in an academic environment was very political. And I had opportunities that were to be supportive of colleagues. I didn't have any leadership opportunities offered except administrative. That happens to a lot of, you know, scholars and minorities that offered to do it. I think sometimes people are afraid you really can't do the science, so we'll give her a job she can do. But I had some experiences in my in these institutions that were discouraging, but I also had insights, and I recognized that I had insights that some of my colleagues did not have about the people in the studies. So I began to build on that, actually. I got myself in big trouble telling people that what they were trying with the clinical trial would not work as well for black people. And it was like the trial and the intervention, that was a gospel, and how could you say that? And it's randomized. And I said, that had nothing to do with it. I know what I took that course. You know? But you can randomize it, but you can't make it work, which is very relevant to this whole question of implementation science. Yes. And I actually did have someone at NIH who pulled some strings to let me analyze the data to actually demonstrate that the black participants didn't do as well in the study. And that led me to think, okay, I have some insights here. If I can learn the scientific and political moves, I do have something to say. And so I continued. When I was at Johns Hopkins, I had one colleague who took an interest in me. I had written a paper that would never have been published had he not sat down with me and said, you know, you've got a point here, but let me help you. Let me help you make it. And that was one of my most recognized papers back in 1980s in epidemiologic reviews, and I really appreciated that. And I've been able to pass that kind of mentoring on to other people, which is something I'd like to do as well.
So, I mean, there are so many things that you just said there, talking about community-based participatory kind of approaches before its time in terms of getting the perspective of the community, and then saying so much about the experience as a minority junior investigator or a faculty member at the institution. Can we just talk a little bit more about that concept of sponsorship? Because it sounds like what you're talking about there, that there was a lot of opportunities that you weren't afforded, but then there were some key people who stepped in at some key times to actually give you not what was not inside of you, but to at least open that door and provide a little extra support for sponsorship. So can we talk about the importance of that, particularly for folks from certain backgrounds?
Oh, it was really important, and I think about it, a lot of the people who, you know, stepped up to help me were from other countries.
Interesting.
Less likely to believe that I had some intrinsic deficiency. And so, you know, would involve me in things and push me. And I noticed that. Someone said to me that, well, we had some of your people before, but they didn't work out, you know, early on in the hire. So So it was a balance.
Yeah.
And I began to recognize the people who treated me as if I had a brain and the people who weren't sure if I should be cleaning their house, you know?
Well, well, let me say, well, I'm so happy that there were people who saw you for you and that we're here today.
Right. And I should actually correct myself, because it doesn't mean that people cleaning their house don't have a brain, but you know what I mean,
I absolutely understand.
academic work, right?
Yes, yes, the limits on what they think you could possibly
What I could do, right,
Yes,
right.
exactly. Now, let's talk conceptually about obesity for a moment, if you would. From a societal standpoint, it is very often the case that individuals think about obesity as an individual failing and think about this as just solely a personal responsibility. And you've written quite elegantly about this broader concept, which you alluded to earlier, about all the other external forces that actually impact our nutrition and our weight, and also the kind of downstream chronic diseases. So can you describe the importance of conceptualizing obesity, not only as not as an individual kind of failing, but in this broader sociological framework?
Sure. I think I'm envisioning various graphics. I like to draw frameworks and graphics. From a public health perspective, the easiest way to understand it is to start at the problem end and then look at what got you there. And this became clearest when the obesity epidemic started, because all of a sudden, people who had the same genetics and other things began to gain weight. It was not confined to the minority populations. When you looked at the different ethnic groups, what you could see is a kind of early warning system, because the populations that had more obesity were those who were the family, community, and larger society context was less favorable, and that manifested itself in part in the foods that they had available and their freedom of movement, which is in the physical activity area. And so probably for me, with my father's being a general practitioner in a very disadvantaged black neighborhood, I could see the differences in what was available there, but also I remember when we moved out near Morgan State College, the suburb, how often my mother went back to that neighborhood to get certain foods or get good prices. And so I didn't know early on what a sociological model was, but as I began to look at it, one of the frameworks we did years ago was called the community energy balance model, and you could just see the individual is the synthesis of all these factors that relate to eating too much or foods that have higher calories and being inactive. But where did that come from? And then you look at the successive contexts that the person is in, and you can see the factors that are unfavorable. If they're unfavorable, they're more associated with obesity. If they're favorable, they may be less so. And one of the layers that we added to the socio-ecological model for this was relationship with the larger environment. Because the minoritization, people call it now, is part of the stress pathways and things that lead to using food, for example, for comfort. I mean, everybody uses it for comfort, but stress is coming from a lot of different ways, job stress, employment, not having employment, worrying about your children. I mean, I have a son, and I remember, even now I would worry about him if he went running around in the wrong neighborhood. So you have all these stresses. You have food as an available environmental risk factor.
Mm-hmm.
And you have the need for, reducing the stress and so forth. So it's, sometimes I have a hard time explaining it because it's so obvious that it's not an individual failing, but, and you also see this in Black literary works, like from Bell Hooks, who said, going for mental health care is not acceptable, but eating the whole cake is, as a way to cope.
To cope.
Yeah. So and probably also cheaper than the mental health therapy. So what made it, I think what's making it obvious is reluctantly people recognizing that the whole population can't have this individual problem.
Yes.
And the colleague who presented recently at our, the National Academy's, the roundtable on obesity solutions, he may even be here at the meeting, but he distinguishes the contributors and the causes, and that helps people to understand. So yes, the causes are somewhere in the physiology of not maintaining energy balance, but the contributors that trigger those causes are in the other layers of the ecological model, and that we can do something about. That will affect the population. Individuals will still vary, but at the population level, those things have escalated to the point where the average person cannot maintain, what we consider a healthy weight.
We're so much swimming upstream in so many ways against so many forces. So now, from an American Heart Association standpoint, of course, we are now seeing a reversal of cardiovascular mortality trends, or at least a plateau and likely a reversal related to the obesity and diabetes epidemics. And its urgency is clear from a clinical and from a public health standpoint. So from your standpoint, there's so many aspects to this complex challenge. So one of two questions. Where do you see where we should be putting some of our greatest emphasis in our kind of concerted efforts at the clinical or policy or community level? Or where do you see as the most kind of exciting frontiers in implementation science around obesity?
Implementation science is in its teens, as one of my colleagues says, who's an expert in the field. It's in its teens now. It's new, relatively new.
Yeah.
And it has a lot of room to grow. I think that what's exciting is that the equity focus is being increasingly prioritized because of COVID, because of some of the racial justice issues. And it's opening the minds of people who do interventions or do research for policy that the intervention itself is not the goal. It's the people who are served by it. And it may sound funny to say you have to convince people of that, but I think when any scientific discipline or branch starts, people become very dogmatic and doctrinaire about it. So implementation science really started, I think, with this healthcare settings, the evidence-based practice, taking all of the research and translating it more quickly. That's what people say implementation science is, to increase translation. And you could not question those interventions before that, but because implementation science keeps showing, well, they didn't get the dose. They took the pills home but never opened the bottle, or didn't follow the advice. And so I think it's exciting because there's a lot of things coming together. There's a pressure for equity to be of greater priority, and there's pressure to embed implementation science more into the research. And if that's done well, it's going to result in new partnerships, broader thinking, more people-oriented thinking. Because once you open the door, the people and the clients, the patients, or the providers who are the targets of the intervention, or the policy implementers will let you know whether it works or not. So I think the field is going to grow. It's going to grow from practical experience, and I really see it as needed, because right now we don't have much evidence in outside of healthcare settings. We don't have much evidence about what works. Because of that, when committees like the Accelerating Progress and Obesity Committee at what was then the Institute of Medicine made their report about what to do about obesity, they couldn't say anything except we see that the playing field is different for some populations, but we have no evidence about what to do. So I think that's very exciting that we're going to get that evidence now.
It's very exciting, I mean, to see the hunger for real-world results, the recognition of the need, and also, as you described, that focus on equity. All right, so I think everybody who's watching this and people who maybe stumbled into it are exceptionally inspired by your career, your work, and your impact. So, but as you very kindly described, not every aspect of that was linear. And there was some, stops and starts and some challenges that you were very kind to share with us. So if you were looking back at your younger self, kind of thinking through this from the lens of, investigators coming after you, what would you say? What would you say that would maybe encourage individuals as they're proceeding on this journey?
Well, I do have opportunities to say things to mentees and so forth, and whether I want to or not, I always say the same type of thing. And one of them is, don't let the system drive who you are. And some of that is for young scholars who think that they come into science for one reason, but after they get in and hear about tenure track or whatever, that begins to define who they are because they're working. I've had young colleagues come in, what's your career goal? I want to get an RO1. And often my mentees are mostly black scholars. And I'll say, why did you decide to get a PhD? Why did you decide to do this? Don't ever forget that. You don't have to lead with your lived experience, or you don't have to lead with your motivation, because sometimes that's not welcome. But don't forget it, and don't trade it. And since I think anybody who's in a distinctive population, I think the marketers call it distinctive populations, a distinctive population knows how to walk in many different ways and code their behavior to the situation. And that definitely has to be done in academia. It's not insincerity, it's context responsiveness.
I like that term. I'm going to use that. Unless it's copyrighted. I like that. That's very nice. But the powerful message on top of that is remembering your why. And that why sounds like it's unique to everybody, and but drives you, gets you out of bed in the morning. That's very exciting. Right. Thank you for the opportunity for us to talk today. Is there anything else that you want to share with the people who are watching?
Well, in terms of the award lecture that I'm giving, I knew Dr. Kritchevsky, and he was a delightful person who played the piano by ear and made up songs for teaching and just to entertain his friends. And so I looked up some of those things. He published a book of those songs, but I could just still see him at the piano playing. He had a song as if I had a big grant that was to the tune of, if I had, or whatever that is. And he did tiptoe. When he taught dental students, it says that he taught, he had a song called Tiptoe Through the Tulips.
Oh, wow.
So anyway, I'm very, very honored to receive this award.
Well, we are very honored to have had the chance to benefit from your amazing career and to have the opportunity to talk with you today and to have you give this lecture at the American Heart Association Epidemiology Conference. So thank you to Dr. Shiriki Kumanyika, and thanks to all of you for watching today.